Thank you so much for joining us. I'm Anna Chodos, and I'm welcoming you to our March webinar, Understanding the New Diagnostics and Treatments in Alzheimer's Disease. We have a fabulous presenter today, Dr. Lawren Vandevrede, and we're going to move on to a couple just orientation slides really quick. This is our CME provider, and the information's here in case you need to reference it. Next one. We have a few financial disclosures for you to just be aware of. Myself and Dr. Vandevrede have put our disclosures up here. Just a couple logistics for today. Dr. Vandevrede is going to be doing the presentation for the most part, but we're going to be looking at the chat and the Q&A. We really prefer you to put your questions in the Q&A, and we'll be getting to those throughout the program. Mostly, though, we'll have an opportunity to answer them live at the end. So we really, really appreciate your engagement. We have a very manageable group today, so please put any questions you have. This is a new topic, and I can imagine that you have some questions. By tomorrow, or within usually at most 48 hours, we have the recording and the slides up on our website for your reference as well. So we usually get that question, and we always look forward to providing those. And then right at the end, usually 5 minutes before the end of the hour, the CME information will be up there for you. These are our presenters today. I think if you've been to a prior webinar, you may have seen me before. I'm the Executive Director of Dementia Care Aware, really here just to kick off the session. The bulk of the time, we have a fabulous presenter, as I already mentioned, Dr. Lawren Vandevrede, and he is an assistant professor in our Memory and Aging Center here at UCSF in the Department of Neurology, and has been really clinically out there with research, out there with doing many, many talks and really building bridges to those of us who are interested in learning more about these new diagnostics and treatments. So we're really, really lucky to have him today. I always also start off our webinars with a quick review of the cognitive health assessment so that we kind of know the starting place of Dementia Care Aware and sort of the orientation of the program, as you see with our compass image here. Next slide, please. Just a reminder that we really promote early detection of dementia. We, as you can see with our motto behind me here, early detection leads to better care. So we've developed this approach based on evidence-based tools that we really are showing people the way and showing how to build this into their care models in primary care, how to do early detection through essentially a screening approach by taking a brief patient history, using validated tools to detect cognitive and functional impairment, and documenting care partner information. This is brief and all meant to take about 5 minutes total. Next slide. We are also, this new year, 2025, we've been spending more time, and you may have seen a prior webinar, really digging into what happens after a positive screen, because screening or detection is really just the first step. So then how do we really get to a full diagnostic workup, getting a diagnosis, and getting people off to a care plan that's going to carry them through, them and their caregivers through living with dementia? So hence, we're doing more on how do we care for patients, what's out there, how can we offer them a different life and a different path when they are living with dementia. So that brings us to our program today. And I just want to plug that we do have a lot of training materials, PDFs, prior webinars, podcasts to help you learn about all the different steps. It's a lot, and it's new for a lot of us. So we really want to be there with you and support you. So without much further ado, next slide, please. I will turn it over to Dr. Vandevrede to take us through what we're hoping to learn today, which is understanding or being able to describe the pathophysiology of Alzheimer's disease, list one way in which biomarkers are used to diagnose Alzheimer's disease, identify 2 criteria for disease-modifying treatments, and finally, discussing the risks of anti-amyloid treatments. So we hope you'll learn all of that, and thank you so much, Dr. Vandevrede, for your presentation today.
Oh, it's my pleasure. Yeah, thank you for the invitation. I really enjoy the chance to come and talk to people who are clinically oriented. I've structured the talk around 3 basic areas, which I think the advances in the last couple of years have been really tremendous in the research world and are beginning to percolate over and be implemented in the clinical side. And so I want to talk about AD diagnosis, specifically precision diagnosis, how to relate the clinical symptoms to the biologic cause. I want to talk about AD biomarkers, the proliferation of tests that are now available to get to that precision diagnosis. And then I want to talk about in the third section, the treatments that are available, the new disease-modifying treatments that are now clinically implemented and available, certainly in many academic centers and hopefully across the country soon. So I'm just going to dive in and start talking about the AD diagnosis. And this is, as with any other aspect of medicine, relating the clinical symptoms to the underlying biologic cause. And I'll start, like any good story, at the beginning with the first clinicopathologic description of Alzheimer's disease, which was done in 1906 by Dr. Alzheimer's. And he carefully observed a patient, Auguste, who probably had a genetic mutation, and saw the cognitive impairment that she had during life and followed her up until her death, when he was able to finally understand the biologic cause. And he used the cutting edge biomarker techniques that were available at the time, which was autopsy and specifically Bukowski's silver stain. And he was able to see the hyperphosphorylated tau that was building up in the neurons. And he was able to see the amyloid plaques that we know now precede that tau accumulation. And he was able to see the result of that protein accumulation, which is the synaptic loss and neuronal death that we see as atrophy or brain shrinkage in the brains of patients with Alzheimer's disease. He was also able to see changes in the immune system, in the immune cells. And I think the story of the immune system in Alzheimer's disease has not yet been told. But he was able to relate that clinical symptoms with the underlying biologic cause. And I think this is helpful because one of the questions I often get from patients is a misunderstanding of this. They say, are you saying I have dementia or are you saying I have Alzheimer's disease? And they really refer to different things. And I think that the definitions of these terms have moved over the 150 years of our understanding and investigation. But when we say dementia, what we really mean is an umbrella term that is cognitive impairment sufficient to impair day-to-day life. That's really what we mean by dementia. And I'm a cognitive behavioral neurologist, so cognitive impairment is one of the key reasons that people present to me. They're having cognitive symptoms and want to find out why. I think it's worth highlighting there's many causes of cognitive impairment. Alzheimer's disease is one cause. And there's many stages of cognitive impairment. Dementia is one, but we found out that mild cognitive impairment can precede that, where you can have objectively measurable symptoms that don't impair your day-to-day life. There's even a stage before that called subjective cognitive impairment, where you're having symptoms, but maybe we don't see it on the testing. And even in the dementia stage, there's mild, moderate, and severe dementia. And so when you say dementia, people often imagine that last stage, the most severe stage of dementia. There's a lot of motor findings, and maybe the patient spends most of the time in bed. But that's like thinking of cancer and only thinking of stage 4. There's really a range of clinical staging that one could potentially have with this, and dementia is just one stage. And importantly, there's many syndromes that can present with cognitive impairment. The memory and navigation problems that patients have maybe in their 70s is only one type of syndrome that patients can present with that involve cognitive impairment. And Alzheimer's disease, when I say Alzheimer's disease, I really mean a specific brain disease defined by specific brain pathology. That's the amyloid plaques and the hyperphosphorylated tau tangles that build up to cause the symptoms that we see. Alzheimer's disease is certainly the most common cause of cognitive impairment, especially in elderly patients. But it's important to remember that even in patients with Alzheimer's, there can be contributing conditions and co-pathology. It's important to realize that even people that present with typical memory and navigation problems in a clinical look a lot like Alzheimer's disease. Only about 85% of those patients with that clinical presentation and syndrome actually have the proteins on autopsy. And so the relationship between the symptoms and the biologic relationship is complex. The way we teach it is kind of towards the top, and I think that's worth understanding because it's the most common presentation, is amyloid building up, causing hyperphosphorylation of tau, synaptic loss, eventually neuronal death, neurodegeneration, you can see on MRI, causing clinical symptoms, which if they impair your function are called dementia. That sort of through line, that relationship, I think is important to understand the biology of neurodegenerative disease. But the reality for a cognitive behavioral neurologist like myself is probably closer to the bottom, is realizing that there's many pathologic changes that can occur in the brain, amyloid and tau accumulation being one. But amyloid can build up not just in the brain, but in the blood vessels, causing something called cerebral amyloid angiopathy. Tau can fold differently in a way that's different from what happens in Alzheimer's disease and cause tauopathies like PSP and CVD, accumulating in different areas of the brain and causing different symptoms. You can have other proteins like synuclein accumulating as Lewy body disease, causing dementia with Lewy bodies, causing Parkinson's disease, and these can co-occur. You can have vascular disease as well, TDP, like we see in frontotemporal dementia. And where these proteins are building up in the brain, which can be variable, creates a pathologic burden, a neurologic burden. This is filtered through the individual lens of the patient, their genetics, their education, age, environment. And this results in a spectrum of presentation, a spectrum of clinical syndromes that we see, which are often differentially related to those biologies, as allow us to predict the biologies with sometimes reasonable accuracy, but sometimes less diagnostic accuracy. These clinical syndromes, we're peering backwards through that lens to try to understand the biology. And I think because of the new tests we have, we can do that with increasing accuracy. So the take-home points from this section is that there's a clinical diagnosis associated with Alzheimer's disease, which is a progressive and insidious onset of cognitive impairment. It eventually impacts daily function, and there's stages, clinical staging, that ranges from subjective cognitive impairment, mild cognitive impairment, and the different stages of dementia. But there's also a biologic diagnosis that gives us a precision understanding of what the cause is of the clinical symptoms, and this requires testing, biomarker confirmation of amyloid, which used to only be done at autopsy. Now we have the ability to do that during life using the tools I'll discuss in the next section. This is where most of the biomarkers are defined as diagnosing AD, but we're also potentially able to stage the disease. Maybe prognostic biomarkers predict the rate of decline. Other neuropathologies might be identified, so we can identify copathologies. That's what we're working on. That's in the research world in biomarkers. AD is one cause of symptoms, but copathology and non-AD causes are common in younger patients or atypical presentations like behavior and language. You can think of Alzheimer's disease because it sometimes causes them, but thinking about the non-AD causes is also important. And just because we can detect AD doesn't mean we should forget about all the non-neurodegenerative causes of symptoms. We know that thyroid problems, vitamin problems, sleep and mood problems can all impact our thinking and memory. So it's important to think about those because they can often be contributing, and importantly, that they're treatable. I'll dive into the next section, talk about all the new tests that are available, all the new biomarkers, and really the wealth, the embarrassment of riches, I think, has been all of the modalities that are available. We've had CSF testing for a little bit over a decade to find the proteins that build up in Alzheimer's disease, the A beta and the hyperphosphorylated forms of tau. We've actually had the amyloid PET scan for over a decade as well. It just hasn't been covered by insurance, but the advent, I think, of the disease-modifying therapies has kind of pushed a coverage determination, has taken this tool, which was previously only in the research world in clinical trials, has now become available in the clinic because we have coverage determinations for it. In addition to amyloid PET, we have new PET techniques, which I'll talk about as well. So in addition to the CSF testing and tau PET, I was telling you about the blood tests that we have available. And I think the blood tests are one of the biggest revolutions that we have because it makes the testing for the proteins that you see in Alzheimer's disease very easy. So I wanted to kind of step through all these different modalities one by one so that you can learn about them with me. But the first one I'll talk about is amyloid PET. Any PET scan involves sort of infusion of a radio tracer. This radio tracer, in the case of amyloid PET, binds to the beta amyloid protein and then lights it up, which is detectable with the PET scan. You can see it here in the bottom left. You can see the results of the scans here on the top right. There is some off-target binding in the white matter. So even in a negative scan, you get a picture, which you can see we describe kind of as like a tree without the leaves, where the white matter is lighting up, but not the gray matter, not the cortex where the amyloid is accumulating. And if the amyloid does accumulate in the cortex, as it does in Alzheimer's disease, then you see the scan on the right, which is diffusely positive, or maybe a tree with all the leaves on it. And that gray-white differentiation is obliterated. You'll see that result in the scan. And I hope you can appreciate on the bottom right, in the left compared to the right, a focally positive, where you can see the off-target binding. But in the bottom right of the picture, you can see that kind of filled in where there's amyloid accumulation. Amyloid PET is read as positive or negative. It's a binary interpretation by an expert reader. Usually nuclear medicine are the ones that read this, but you can also quantify the signal using a scale called centiloids. It's meant to parallel Celsius scale, where 0 is negative and 100 would be like the early stage of AD dementia, and ranging in between there. But just like Celsius, it can go negative, and it can go up to like 200 in the later stages of Alzheimer's disease, where there's more amyloid accumulation. The positive negative threshold visually is right about centiloid value about 25, and that's considered negative on the quantitative scale as well. So that's about where people transition from a positive to from a negative to a positive. The advantages of this test is that you can visualize the burden and the distribution. You can quantify it. And importantly, if you think about the anti-amyloid treatments, you can actually track the amyloid plaque removal, because you can look at the centiloid scale and say how much you've actually removed. And the goal of the anti-amyloid treatments are to take a positive scan and turn it into a negative scan because of complete clearance of the amyloid protein. One of the major advantages right now for amyloid PET is that there's a clear insurance coverage determinations. The Center for Medicare and Medicaid has said that this is covered for the diagnosis of Alzheimer's disease, especially for considering patients' eligibility for treatments. And because other insurances tend to follow along as a result of that, at least in the treatment clinic, we haven't had any successful pushback on getting insurance coverage for patients that are trying to qualify for treatment. The drawbacks of PET are somewhat obvious, I think. It's expensive, it requires specialized equipment, highly trained personnel. It's not available at every center. It does involve a small amount of radioactivity, which is a concern for patients. And then importantly, it's quite expensive. The cost is actually about $5,000 a scan. That's the cost of the radio tracer. And the reimbursement was quite poor, so it was actually a loss leader for institutions, that every scan actually was generating a loss because of the reimbursement, though that's changing now. Tau PET is similar to amyloid PET, but detects a different protein. This one is the same basic idea with the scan and the radio tracer, but it binds the tau tangles. And it's relatively specific for that type of tau that you see in Alzheimer's disease. We know this from PET to autopsy studies. We're able to match up the signal that we see on PET with where we see those proteins at autopsy. And this is read as visually positive or negative, though the way that you approach that is different in the two cases, in tau PET compared to amyloid PET. A little bit more technical in the approach. You need to be able to look at certain areas and threshold it a certain way. You are able to quantify this signal as well with tau PET, though this is an ongoing area of research. One of the main advantages of tau PET, I think, is that you can see the burden and distribution of tau tangles, just like with amyloid PET. But unlike with amyloid, the location and degree of tau correlates with the symptoms they're having and the disease severity. And I think I illustrate this here with two cases I just pulled from our clinic. These are atypical presentations of Alzheimer's disease, where it's not a memory and navigation problem. Like in the logopenic variant, the primary problem is actually language. And I think you can appreciate the asymmetry of the tau accumulation, where it's more on the left compared to the right. And this correlates with where language centers are in the brain. So you can see more on the left than on the right. And contrast that with the image on the right, the posterior cortical atrophy, where the tau accumulation is typically in the back of the brain and can cause symptoms related to vision and visuospatial organization. So having that ability to quantify the amount of tau does allow you potentially to biologically stage the disease. And the most recent publication from the Alzheimer's Association actually proposed a schematic by which you could quantify, sort of just like in cancer 1, 2, 3, and 4, A, B, C, and D, with the biologic stage to match maybe that clinical stage that you've got with the MCI, SCI, and the different stages of dementia. The drawbacks of this are the same as amyloid PET. It's expensive, requires specialized equipment, highly trained personnel, small amount of radioactivity. The cost of this scan is roughly twice as much, so $10,000. The insurance coverage is very unclear. You certainly don't want a patient getting stuck with a bill that big. For Medicare, for certain indications, at least in the treatment clinic, we've had success getting coverage for this. But I think this is something that's being actively explored at academic centers like ourselves, so that we can understand how best it can be used. CSF testing, I said, has been available for over a decade. You collect cerebrospinal fluid, which surrounds the brain. You can measure the proteins that build up in Alzheimer's disease. Unfortunately, you need a lumbar puncture to get cerebral spinal fluid, or it's also called a spinal tap. When you interpret it, they measure several proteins, often give a ratio, or talk about how the proteins are related to each other with a cutoff value that gives you a positive, negative, or intermediate result. But you do get continuous values actually provided, so you can look at them individually. But really, it's that ratio that is validated against PET or autopsy. The main advantage of CSF testing, I think, is that you can test for things that aren't AD. So if you've got something else on the differential, like we can test for synuclein, like you see in Lewy body disease, like dementia with Lewy body or Parkinson's, we have a CSF test for that now. You can test for both at the same time if that's on your differential. You can look for inflammatory changes that can be seen in autoimmune disease. You can look for cancers. And we have additional tests in CSF that aren't available yet in blood. So I think that's the advantage that you have for CSF. And it's covered by most insurances, certainly for the diagnosis of Alzheimer's disease. However, even though it's been available for over a decade, it really didn't become a routine part of care, I think mainly because of the drawbacks and barriers. Patients often have a negative stigma around lumbar puncture. Some patients have contraindications like being on anticoagulation, having scoliosis, or prior lumbar spinal surgery. I'm the director of the LP clinic. These are very time consuming. They're expensive to set up. They're poorly reimbursed. They're even occasionally unsuccessful. Even the best proceduralists can miss a lumbar puncture, have to go to CT guided, and it can cause side effects in patients, which is rare, but can be potentially impactful. And so patients don't want to do them. The providers aren't incentivized, and institutions aren't incentivized either. And I think this is the reason why you haven't seen a precision diagnosis in Alzheimer's disease until now. And I think one of the reasons is because we have blood tests in addition to the PET scans, both coming on the scene at the same time. And a blood-based biomarker, the procedure is very straightforward. You go and you get blood drawn. They measure the same proteins that you see in cerebral spinal fluid. It really has been a technological advance, the ability to detect the protein at the lower concentrations where they're present in blood as opposed to cerebral spinal fluid has been the major technological advance. The interpretation is the same, positive, negative, or intermediate, because there's a range in which it can be hard to distinguish between the two. And you do get continuous values. I think the advantages of blood testing are pretty straightforward, very acceptable to patients to do blood work, very accessible, easy to scale, very low burden to the patient. It's also less expensive than the other modalities and has similar accuracies. And blood work is a routine part of the current medical paradigm. Doing blood work to work up a clinical symptom, I think, is understood, so easy to incorporate in clinical practice. The drawbacks, I think, are mostly related to where we are right now in history. Because they're new and because they're accessible and scalable, there's really been a proliferation of blood tests that have a lot of variability in their accuracy. Some of them are really no better than a coin flip, where some of them are as good as cerebrospinal fluid testing. And this can be really difficult to parse for non-experts. There's a lack of reimbursement or inconsistent reimbursement because there isn't FDA approval or coverage determination for these tests right now. They do exist, but it's unclear whether they're going to generate a bill for the patient. And there's certain peripheral factors that can impact the test results. Really, kidney disease is the main one. Patients with kidney disease can generate false positives in patients, extremes of body habitus, or even motor neuron disease. So there's some nuance in the interpretation that requires education on the part of the ordering clinician to be able to interpret it accurately. When you're dealing with something that has the stigma associated with it that Alzheimer's does, being accurate is really important. So we've created guidelines. We've published recently with Suzanne Schindler in Alzheimer's and Dementia about biomarker implementation in the clinical practice and talking about all the different biomarkers that are available. I really view it as an opportunity. Having multiple modalities means that you can come up with an individualized approach for your patient. You can choose the test that's right for them that will have the most accuracy that's needed to answer the question that you have. But some of the considerations about which test to order I have in tables like this one, which are in the document that's referenced. I wanted to go through some of the analytes that you measure and some of the tests that were available and talk about a couple of cases. But the two main two main proteins that you measure are amyloid and tau, just as we mentioned, that are the core of Alzheimer's disease. You can look at the ratio of A beta 42, which is the bad form of A beta, to the normal form, which is A beta 40. And it actually decreases, A beta 42 decreases in disease in CSF and blood because it's retained in the brain. In the figure here, you've got people with a negative amyloid PET and a positive amyloid PET, and the red dotted line is the cutoff, and you can appreciate on a group level that there's a shift, that there's lower amyloid beta ratio in the PET positive group, and this helps you be able to predict that PET positivity with reasonable accuracy. And it does seem that the A beta ratios are sensitive to early amyloid accumulation. They turn positive, like the PET scan, even 10 years before there's clinical symptoms. We know that people can develop this protein buildup even before there's overt clinical symptomatology, though if you follow those patients long enough, they will develop clinical symptoms. But the fold change is not that high. Like if you look at that red dotted line, everybody on the same level, you can't distinguish between the two groups. There's a lot of overlap between the two. So to be able to get to a reasonable level of diagnostic accuracy, you have to combine these ratios with other things like age or ApoE status. And so this was the first test that really became available, but didn't get used very often because it didn't have high diagnostic accuracy, though it may work better at early stages of the disease. What's now become clear is that a specific form of the protein tau seems to be the gold standard blood test for measuring or for diagnosing Alzheimer's disease. The specific form of hyperphosphorylated tau in CSF testing was called p-tau 181, and that was actually the first blood test that became available as well, and I'll show it in the cases that I've got later on in the presentation. But it was our group as well as others here at UCSF that showed that p-tau 217 is actually a little bit better, not because of anything having to do with the biology, just because of the degree of change between people with the disease and without, that allows it to be able to more accurately identify patients with Alzheimer's disease. And it's even been shown on certain platforms, this is the one that's equivalent to the cerebrospinal fluid test. So this blood test is as good as the one requiring a lumbar puncture. Very accurate when measured against autopsy, even works independent of the clinical presentation. So it doesn't really matter what the symptoms are that you see. It can detect the proteins pretty accurately, and even can be used, at least in a Swedish study they've shown, in primary care settings to identify patients with the Alzheimer's disease buildup. In symptomatic patients, it should be stated. So this really is the kind of gold standard leader for the diagnosis. And so just to talk about how this analyte has been incorporated in a couple different tests that are actually available clinically. There's two main groups. There's a mass spectrometry-based method to detect it, and another one called an immunoassay. I'll talk about that next. But the main test within the mass spec assay is called PrecivityAD2. It's by a company called C2N. They measure 217, phosphorylated to non-phosphorylated. They measure the ratios, and they create an amyloid prediction score to predict PET positivity. And in head-to-head studies, it seems like this has a little bit of an advantage, a little bit of increased diagnostic accuracy. This is the one that's been shown to be comparable to CSF testing. The cost of this is quite high still. $1,400 is the list price. There's still not clear insurance coverage. There's no FDA approval yet. There's no coverage determination from CMS or other insurances. There are financial assistance programs, but this uncertainty actually creates quite a barrier because no one wants the patient to have a cost associated with their testing or to not know what the cost would be. It can be somewhat cumbersome to incorporate in the clinical workflow. All of these tests can be. This one in particular requires sort of cold chain storage. It had to be maintained at a low temperature until it gets processed and tested. Though with the kit, you can actually do at-home blood draw testing, which is an advantage. Some of the other companies have this available as well. The other approach is using an immunoassay. There's three big platforms that develop lab-developed tests, Fujifilm, Roche, and Quanterix. And there's several companies that have used these tests to develop specific orderable tests for your patients, like Mayo, LabCorp, Quest. You've got them here, Allspath, Janssen on the Quanterix assay. But you can see I've put now sort of almost 8 tests up, and being able to determine all the diagnostic accuracy between these tests, where to get them, what the process is to order them, what the cost is going to be. To a non-expert, this becomes bewildering very quickly. And I think this is probably one of the key barriers, is that we almost have too many options to choose from. But I think that over the next couple of years, this will really sort itself out, and we'll be able to develop guidelines to advise people on which tests to order and how to get them for their patients. But I think I say usually the best test to get for your patient is the one that you can get and the one that you have relative certainty in being able to interpret. That's the best test. I'll talk about the appropriate use right before we talk about the cases for clinical AD biomarker testing, when you would consider it. But I can I can summarize this, I think, in a few words. If you're working a patient up that has cognitive symptoms and you're considering AD as a potential cause, and you think the test is going to help, that's probably reason enough to be able to order it. And I think in most patients that are presenting with cognitive and behavioral symptoms, as part of the workup, you probably want to know, unless there's a clear explanatory reason, whether Alzheimer's disease is contributing or not, especially because there's new treatment options for patients in the symptomatic stages. But to highlight a few key things is we don't recommend testing patients without symptoms. In that population, the prevalence of Alzheimer's disease is lower, and that affects the diagnostic accuracy of the test. You can generate a lot of false positives if you test people that don't have symptoms, leading to a lot of worry because you're giving them a diagnosis that has a lot of stigma. It generates a lot of expensive additional testing that's needed to be able to rule out that cause. And so really, I think this is intended for people that have clear symptoms that you can identify, you're considering AD, and then it would benefit you or the patient in some way to have the result, either by increasing the accuracy of your diagnosis or qualifying a patient for treatment. I will say that anti-amyloid antibodies are one treatment, but even donepezil, why have a patient on a treatment for Alzheimer's disease that works for Alzheimer's disease if they don't have it? And again, if the clinical diagnosis is only 85% accurate, 15% of people might be inappropriately treated. So just thinking about that. I want to dive into the cases here. And I want to stress these are real world cases. These were pulled because blood biomarkers were incorporated into the Memory and Aging Center clinic a little over a year and a half ago. I just looked back to see how people were using them, to see what the context of use there were. And this was an earlier generation. This is the p-tau 181 test, which is the first one that was available. And you'll notice that people are often sending the neurofilament test. I didn't mention this, but it's a non-specific marker of neurologic injury. Anything that affects the brain and causes injury to the brain cells actually causes NFL to increase. And in neurodegenerative disease, though, that injury is so low that on a group level, you can see a difference, but oftentimes on an individual level, you don't see an elevation in NFL. Whereas in like stroke or MS or a traumatic brain injury, you can really see dramatic spikes in the neurofilament change. So it's most often actually negative in neurodegenerative disease. Anyway, so this is one of the most common uses that I saw was sort of as an initial evaluation step prior to more expensive testing or a triage. And this was a 79-year-old woman who had some vascular risk factors. She comes in with 2 years of progressive memory and navigation problems. It's a typical presentation of Alzheimer's disease. The symptoms have begun to interfere with her day-to-day function. Her neurologic examination is normal, as it often is, but neuropsych testing shows trouble with delayed recall, trouble with visuospatial tasks, and the mini mental state examination, which is a quick screening tool for cognitive symptoms, was impaired at 25 out of 30. If you look at her MRI on the right, you can see precuneus atrophy, one of the earliest areas to be impacted, as well as hippocampal atrophy. And you don't see, but there's a mild burden of white matter disease. So the clinical diagnosis here is mild dementia because her symptoms impair her day-to-day life, but we have relatively high suspicion for AD because of the pattern, the MRI findings, and the MMSE testing, the neuropsych testing that we have. And lo and behold, on blood biomarker testing, she's elevated about threefold over the upper limit of the reference range. And these initial generation of these tests were not meant to be standalone diagnostic tests. They were meant to be paired with the gold standard CSF and PET testing. So an amyloid PET was ordered, which was diffusely positive. And because the AD was confirmed, she was a good fit and otherwise eligible for disease-modifying treatment. I'll talk about that in the last section. She was actually approved for lecanemab and treatment was initiated. I would say, in some ways, I think this is a snapshot of what the future probably looks like, using these tools to maybe screen for or increase our certainty for Alzheimer's disease, maybe needing additional confirmatory tests to qualify for expensive disease-modifying treatments. But it could be the case that these blood biomarkers are even used in primary care settings in initial triage fashion. It's useful in atypical presentations. I mentioned this is a case, these are real world cases again, 58-year-old woman, high blood pressure, fibromyalgia, chronic fatigue syndrome, irritable bowel syndrome, PTSD, and anxiety. She comes in for 2 years of relatively nonspecific symptoms described as brain fog. Her neurologic examination had maybe a component of functional overlay, but neuropsychological testing did find deficits in learning, memory, attention, and processing speed. And her MMSE is not normal. It's it's still in the okay range at 28 out of 30, but not normal. And her brain MRI, I would say, fairly reassuring for her age, but there's maybe some mild asymmetric atrophy. So the diagnosis was mild cognitive impairment because she's got symptoms, and they're objective on testing. The overall suspicion was thought to be low for Alzheimer's disease, but this could be an early onset form of Alzheimer's disease, which can be more executive and occurs in people under the age of 65. So I'm not sure 10 years ago that this patient would have been routed for a lumbar puncture because of the invasiveness and the stigma associated with it. But because blood biomarkers were available, she was tested. Her 181 was found to be elevated. It's a positive test at 1.5-fold. A follow-up amyloid PET scan did show amyloid accumulation focally. She was in the early stages of amyloid accumulation. So she was considered positive with concordant biomarkers. She was considered for disease-modifying therapy, ultimately declined. There were things to work on in terms of lifestyle modification. But now she has the diagnosis. She's aware of it, can consider disease-modifying therapeutics in the future. I think we're going to see this type of case more and more, mixed etiology dementia. 87-year-old woman, high blood pressure, high cholesterol, hypothyroidism. She comes in with at least a year of cognitive changes. This was sort of beginning to fail at home. Kids kind of discover that maybe that the support systems are not sufficient any longer. Not exactly sure when it started because maybe the changes have been so slow, glacial. But she's brought in now for evaluation. Her neuroexam shows trouble visuospatial tasks. Neuropsych shows trouble with visual construction, recall, so delayed recall, so memory problems, naming generativity, sequencing, and her MMSE is 22 out of 30. Her MRI, you can see on the right, I hope, has some at least moderate hippocampal atrophy, scattered white matter disease, including in the brainstem and pons, and one lobar microhemorrhage. So the diagnosis was a multi-domain moderate dementia. Deficits were in visuospatial and executive function, but she did have memory. Suspicion was thought to be high for Alzheimer's disease, which pretest probability in an 87-year-old would make sense. But lo and behold, her p-tau 181 was half the reference range, so it was negative. But her NFL was elevated, suggesting there might be other proteins. TDP, we know especially, can elevate NFL. And she had a follow-up amyloid PET scan, which was negative, which confirmed the blood testing. So now we've got a patient that we have very low likelihood of AD being explanatory for her symptoms. So having a differential diagnosis for this, I think, is increasingly important. And in her case, it was thought to be a contribution from vascular disease, something called late, which is TDP accumulation in the hippocampus, which is a common AD mimic, especially in older folks, and maybe cerebral amyloid angiopathy is contributing. So I think this is, 10 years ago, 15 years ago, this patient probably would have been called Alzheimer's disease, started on donepezil. I maybe wouldn't have found out that she was in that 15% of cases that we get wrong until autopsy, but we're able to get an accurate diagnosis now immediately. This context of use is probably maybe the most controversial. This is in a patient with lower suspicion of disease. Again, we don't recommend asymptomatic patients, but this is a 69-year-old woman. She has insomnia, anxiety, a positive family history for AD. She's actually been followed in clinic for 5 years and initially got a lumbar puncture looking for Alzheimer's disease, which was negative. But 5 years later, she says, I've got worsening memory symptoms. Her neurologic examination is normal. Her neuropsych testing is average, but she had high educational achievement, so this was thought to be potentially a relative decrease for her, but nothing objective on neuropsych testing. Her MRI was fairly reassuring, maybe some mild hippocampal atrophy for a 69-year-old. So the diagnosis was subjective cognitive impairment, but there was suspicion for neurodegenerative disease given her positive family history, maybe relative decrease on neuropsych testing. So after extensive counseling with this patient, the decision was made to send the blood biomarkers with the explicit understanding that they would be useful to rule out, but not rule in, because the negative predictive value would be high, but the positive predictive value would not. And reassuringly for this patient, they were negative. She was actually tested again the following year, and they were again negative, and this ruled out Alzheimer's disease, which was reassuring. And ultimately, she was found to have new obstructive sleep apnea, which was probably explaining her cognitive symptoms. This is SCI with high suspicion. So the take-home points, I would say there's lots of new biomarkers that are clinically available to diagnose Alzheimer's. Cerebrospinal fluid and amyloid PET have the longest history of use, clear coverage determination. Tau PET shows promise, especially maybe as biologic staging and identifying atypical cases. That's not really part of routine use yet. And there's several blood-based AD biomarkers that are clinically available. I think 217 looks like the best as it stands. But availability, cost, insurance coverage, and the nuance and interpretation are educational, I think, surmountable barriers for their use in clinic. But it's going to take us some time to sort that out. And I think that's a lot of what we're doing here is trying to educate people about these new tests and create guidance for them. Okay, so in the last bit of time here, the last 15 minutes or so, just want to talk about the new disease-modifying treatments that are now clinically implemented. I'm a clinical trialist, so I was using these back in the clinical trial days as well, and was part of the team that brought them into the clinic. I won't belabor this point because I think this is, sort of inside baseball and maybe only interesting to me, but it was 20 years of drug development that it took to get these two drugs into the clinic. There were so many lessons learned along the way about the importance of biomarker confirmation, knowing that patients had the disease that we thought they had, being able to monitor for the major side effect of it and stop the treatment if needed, to be able to use appropriate biomarker confirmation to know that drugs did what we think they did, to have the right outcomes so that we knew that we could track and make sure that it was clinically meaningful. That's really the success story here, the development, this iterative development. And I refer you to the paper by Adam Boxer and Risa Sperling, published in Cell in 2023, if you want to read it. I think very interesting. But the end of the story was two drugs that were FDA approved for the treatment of Alzheimer's disease. This is lecanemab and donanemab, marketed as Leqembi and Kisunla. They both show what I think is a class effect of these drugs, which is a slowing of the progression of the disease. It does not stop, it does not cure the disease, but it does slow it down by about 25 or 30% on average in carefully selected patient population. And that's really been a revolution, I think, because we've never been able to do that. We've never been able to affect the progression of this disease before. And so these are our first disease-modifying treatments for AD, and these are what we're rolling out in the clinic. And we do think that the effect is tied to the amyloid removal. If we look at all these different trials that were clearing amyloid from the brain, it does seem that the clinical benefit, the slowing on this measure called CDR, does seem to be associated with the degree of amyloid that's cleared as measured in the centiloid score. So we really do think that this is related to the amyloid clearing and is probably the strongest support for the amyloid cascade hypothesis. What are these drugs? They're antibodies. I think I've said that, but an antibody is like made by your immune system to like attack viruses and bacteria. And this is engineered to identify the amyloid plaque so that your body recognizes it as foreign and uses the immune system to clear it. The drugs do this. There's no question that the drugs clear amyloid from the brain. We can see that on the amyloid PET scan, which I talked about before. You can see here in placebo after a year some accumulation of amyloid, but after treatment with an anti-amyloid antibody, you can see really remarkable clearance. Not that the clearance is the goal is to slow the disease, but with really a sufficient clearance of the amyloid protein, you can see this slowing of disease progression that's incomplete. But this is why they're considered disease modifying. And just to state the difference between disease modifying and symptomatic, the progression of Alzheimer's disease is typically through stages: relentlessly progressive, mild cognitive impairment, dementia, institutionalized care, and ultimately death. And the natural history of Alzheimer's disease in an untreated patient can be visualized as going from A to B. A symptomatic treatment like donepezil might provide you a little bit of a boost in focus and concentration, often difficult to notice for patients. You can go from A to C, shifting a bit on the y-axis. And the effect of this, even though the slope isn't changed, is that you can see a delay in the progression to each one of the stages. And this is what Cochrane reviews and others have shown is the benefit of donepezil, about a 6-month reduction in placement in an institutionalized facility. That's really the clinical benefit of donepezil, even though there is no mortality benefit because it's a symptomatic treatment. Whereas in the anti-amyloid treatments, we think they're disease modifying, so you might not see an immediate functional benefit, but what you see is a delay in progression to the next stage and hopefully overall a mortality benefit. And when you calculate as time saved, it ends up being somewhere around 4 or 5 months over 18 months of treatment. And if you multiply that out times the 8 or 10 years of the disease, if you really are changing the slope, that can mean an additional year, couple of years in the earliest stages of the disease, and I would argue that's clinically meaningful to patients. Importantly, if you measure it at disease X, I think a symptomatic medicine and a disease modifying might actually show the same benefit, but really it's what happens after that that really matters. And just to say the hazard ratios for these drugs in delaying progression to the next stages of the disease, I think stand up to most other tools in modern medicine. There is no benefit without a cost. The major cost here is ARIA. This is amyloid-related imaging abnormalities. This is related to immune overactivation from the drugs, against using the immune system to clear. So it's related directly to what the drug is doing. You can see swelling in the brain or edema. This is ARIA-E, one of the two flavors. You can see a severe case here on the left. You can also see bleeding or hemosiderin deposition. Because the amyloid accumulates not just in the brain, but also in the blood vessels. When you pull it out, you can generate instability or these microhemorrhages, which you can see in the normal course of the disease, but increase with treatment with the drug. A microhemorrhage in and of itself is probably not clinically significant, not going to cause symptoms in a patient, but it's really the worry of a microhemorrhage becoming a macrohemorrhage. And we know from cerebral amyloid angiopathy, just the natural history of it, untreated hypertension, anticoagulation, these things can really increase the likelihood of it being a clinically significant macrohemorrhage. So this is what we worry about and why we don't allow patients with anticoagulation to be on these medicines and make sure that they don't get the strong clot busting medicines like TPA, like you would get with a stroke or a heart attack or a clot. And ARIA is manageable. Most of ARIA is actually asymptomatic. We just see it on the scan. We call the patient up. They say, I don't notice anything. It's safe to treat through if it's mild. Even if it's moderate and symptomatic, if you stop the medicine, the swelling and the edema will resolve, the symptoms will resolve, and it's safe to retreat the patient. But what really matters, I think, is severe symptomatic ARIA, big changes in the brain associated with symptoms. And this does occur, so it needs to be talked about with patients, but it is rare, on the order of 1% with these traits. And being able to identify those patients that are increased risk is very important. Most of management of ARIA is the treatment pause. You can modulate the immune system activity just by withholding the drug. So if they're moderate intensity or symptomatic, you can just stop and monitor more intensely. And if they resolve and stabilize, you can actually even restart the drug. And if they have severe symptomatic ARIA, you have high-dose steroids in your back pocket, you can actually turn off the activity of the drug. And those are quite effective. It's really important to select the right patient. These drugs really work in the earliest stages of the disease. They work best in the earliest stages of the disease. That risk benefit actually flips right around moderate dementia, and the risk of ARIA increases and the likelihood of benefit decreases. And so really patients with MCI or mild dementia are the ones that should be selected for eligibility for treatment. We operationalize this as like an MMSC at 22 out of 30. You have to have amyloid confirmation. You have to have amyloid to use an anti-amyloid medicine. CSF and PET will qualify. Here you can qualify with plasma, but we often will order PET because we want to be able to monitor. And it's not clear that plasma is up to the task of monitoring, though we're investigating that. And certain imaging findings, like lots of white matter disease, strokes, prior bleeds, these are considered disqualifying for treatment. We order ApoE testing. This is the risk gene in Alzheimer's disease. 4 is the bad one, epsilon 4E4. People have 2 copies at increased risk for Alzheimer's disease, but more importantly, in the context of these treatments, at increased risk for ARIA and the more severe forms of ARIA. And so we really test ahead of time to be able to inform the patient on an individualized way about their risk and benefit. And here we've chosen not to treat patients on anticoagulation here at UCSF, again, out of the fear that these microhemorrhages may become macrohemorrhages, which are more clinically significant. These aren't necessarily appropriate use recommendations, but we developed protocols around giving these medicines across the entire UC system. We worked with folks across the UC system to come up with the protocol. We've revised this to include donanemab, which was more recently approved. We have these protocols available. We're happy to share them with anyone that's interested in learning more about the logistical and operational what's involved in actually providing these medicines to patient. It is not a small lift, I will say. We have some patient-facing documents about what these medicines are, what the risks and the benefits are, and about ApoE testing, and more than happy to share those for anyone that's interested. These are meant to be freely available. We've worked with organizations like the Global CEO Initiative to talk about what it would look like to implement these treatments and these tests in secondary care and primary care settings. I know we're kind of all thinking about what this screening looks like. I know Dr. Chodo says as well about how do we identify patients early? That's where they benefit most from the disease-modifying treatment. But also there's importance just in getting the diagnosis to patients, because I think a diagnosis is therapeutic in most cases. But what this looks like logistically, what the tools that we use for screening, what the stages are, this is still very actively debated. But as it stands now, I do think that these medicines are quite complicated to administer in some ways and do have a high rate of side effects. So probably are going to be in the hands of specialists like myself, though increasingly they're being used in other settings, which I think is appropriate, assuming that there's sufficient knowledge about how to monitor for the side effects and select patients. I think that's okay. But as these treatments become safer, which the next generation look like they are, and become easier to administer, which I think is going to happen with different modalities of delivering over the next couple of years, I think you're going to see the shift out into the general neurology community and really perhaps even into the primary care setting if we can identify champions that are dementia specialists that are willing to learn how to administer these medicines in an appropriate way. I think that's really what the next 5 to 10 years look like, because there's just not enough cognitive neurologists to be able to treat all the patients as we move into a more interventional stage of the treatment of Alzheimer's disease and the precision diagnosis using all the tests that are available. You probably have a lot of questions about these drugs. I still have a lot of questions about these drugs. We've built a research infrastructure at UCSF to be able to begin to answer them. If there's a benefit, who benefits, what are the characteristics of people that benefit, how early or late can you go, how long should we treat, can we stop and monitor, how do we evaluate the treatment response, how do we better monitor and detect ARIA? That patients need like 4 MRIs in the first year. We got 4 scanners downstairs that are going, but that's not possible everywhere in the country to be able to have that many MRIs for every patient that needs it. So we need to come up with alternative ways to be able to screen for and treat ARIA. Can you use combination therapies? 25% slowing, I think it is clinically meaningful, but it's not enough. It's not where we need to be with this. And if in 5 or 10 years, these are the only medicines I have, I think we failed in important ways. But I think combining this medicine with other treatments like tau-based treatments or immune modulators, this will make it look more like what most chronic diseases like cancer or heart disease, where you've seen success, it'll look more like those diseases. And we'll be running combination trials here at UCSF with Adam Boxer and Keith Johnson. And the Alzheimer's Association has put together a national platform by which they'll collect data from patients that are on these medicines to be able to determine what the outcomes are, who benefits, and be able to answer some of those questions that I mentioned. And those will be available for qualified collaborators. And I'll just end in the last minute on a hopeful note here and say, I really think that we understand the disease fairly well now. We're beginning to perturb it, to pharmacologically remove the key neuropathologic instigators of the disease. I think that means that we're moving the needle in terms of slowing down the progression. I think tau is the next big target out there because we can completely clear amyloid from the brain in the early stages, and we know what the benefit is, but it's an incomplete response. There's all these other approaches, but oxidative stress, neurogenesis, neuroprotective, pro-cognitive, immune modulators. This is actually a picture of the Alzheimer's disease pipeline. I tell my patients, I can't even keep up with all the drugs that are in the clinic, in clinical trials for Alzheimer's disease. But I think it's a really hopeful time, as we build towards combination therapies, and assuming we can keep this momentum going, which is not a settled question, but if we can keep this momentum going, I think we can really make Alzheimer's disease a manageable chronic illness. But I'm an unapologetic optimist, and that is admitted. That's it for me. Thanks so much for listening. I appreciate the attention.
Thank you. That was really, really helpful, and I think a really clear overview of what you're doing every day, treating patients. We have some great questions. I'm going to bunch them. So some are in the realm of the blood-based biomarkers and how those are working, and then the other treatments. So we'll start with treatment since we just left off there. I think you explained it again pretty well with the take-home points, but do you want to just sort of say how you communicate to patients and colleagues, like what the new drugs are doing? Is it disease reversing? I know we call them disease modifying. And somebody asked, I thought this was really provocative. Will there be a role for these sorts of medications in prevention?
Oh, yeah. So I'll start with that because I think it's the earlier you treat, the better, we think. And there's two large primary prevention trials enrolling thousands of patients who just have a positive amyloid PET scan. They were screened for with blood biomarkers, and they have no symptoms, and they're being treated with the hope that they'll prevent the symptoms ever from developing. So we'll know that answer to the question in a couple of years. And our hope is that we can intervene at that stage with the anti-amyloid medicines and actually have more of a benefit, whereas we might need other different targeted medicines when people are in the symptomatic stages and they have more entrenched disease. I kind of explain this to patients. I say, you're driving in a car towards a destination you don't want to go, which is the next stage of the disease. You're going 60 miles an hour. And I can slow that car down to 45 miles an hour, about 25% or so. If you're sitting in the car, without a speedometer, you might not even be able to see that. And you're still seeing the progression. You're still seeing the landscape go by. But I know it's going to take you longer to get to that destination that you don't want to go to. So that's what we're aiming for with the disease. With the treatment of it. And we can at least tell you how much amyloid we've cleared if we use the PET scan to tell you what the biologic response is. And it is challenging to say that you've slowed down the clinical progression because people progress at different rates. And we know on average how people progress, but averages don't apply to people. And so that can be quite challenging to see. But I do think it is impacting the disease, and it's worth kind of straining, especially in those patients that are at the earliest stages, that you can really clear amyloid quickly and they can get to negative. I think that's where you see most of the benefit. I'm less excited about starting people in that MMSE 22 stage than I am in the MMSE 29 stage that are just beginning to be symptomatic. I think that's really where the benefit of these medicines are.
That was awesome. Yeah, I really appreciate how you that metaphor. I bet a lot of people can sort of understand what we're talking about with that. Okay, I think the other questions were around the testing, and essentially the two sides of the questions were, or the two types of questions were, which blood-based biomarker are we really recommending? And I think you're pretty clear it's the tau 217, right? And then that's sort of the best one, and some of the other ones are out there and they're being marketed, but we're not really recommending them or know what to do with the information. Is that right?
I think so. I mean, it was a patient I just had in clinic yesterday, and she had the ratios tested and 181 tested and had an amyloid PET. And the ratios were normal, and the 181 was positive, and the amyloid PET was positive. And she said, "What does this mean?" And I said, "Well, these two are really good tests, and this is the gold standard test. And given your clinical presentation, I have high suspicion that it's Alzheimer's disease." We ultimately triaged her to treatment clinic to start treatment. But I think having that ability to interpret all of the different tests can be quite challenging. But I do think that 217 is probably seems to be emerging as the leader. But even with 217, there's all these different platforms and tests that you can choose from. So it can be slightly bewildering, I think, right now to be able to parse between these. And it's such a fast-moving field that anything I tell you right now will be out of date in 3 months. So we're trying to come up with ways to create living documents that can provide guidance about diagnostic accuracy so you can choose the best test for your patient.
Okay, and I think we're going to revisit again some stuff you mentioned, but maybe we can just crystallize it here. How do you see them being folded into practice? Especially, let's take, for example, a rural area where access to all these other things might be pretty slim, but actually someone can get a blood test.
Yeah. In some ways, this is just about diagnosis, right? So, you've always been able to diagnose Alzheimer's clinically because we know what its pattern is. The most common presentation is atypical presentation. And we've had relatively complex ways of getting the biologic diagnosis to increase that certainty. So some of these are just questions about, getting the diagnosis. And I think you should try to get to the most accurate diagnosis that you can. And if you don't have all the tools that are available, that's our failing because they need to become available. But these blood tests are going to be scalable. They're going to be available in places where somebody that knows how to do a lumbar puncture is not, or where a PET scan is not. So this will make that diagnosis, I think, easier in those areas. But you need to be able to know that that test is accurate, interpret the nuances around it, and make sure you're ordering it in the right patient because I'd say any tool that you have is potentially powerful, but powerful tools can also be dangerous in the wrong hands. And giving somebody a diagnosis of Alzheimer's disease when really all they have is chronic kidney disease that's artificially pushing up the analyte, that's the thing that kind of keeps me up at night, that worry about. But
Mm.
that's, I think, surmountable with education, like you're doing here, like we're doing. It's just teaching people how to use it. It's like any other test that we have. It's just new, and we have to kind of teach people how to use it. But I think it's going to be used in anybody that presents with cognitive symptoms, because as part of a comprehensive workup, and exactly where that occurs, I think, is still a matter of debate. I'm not sure about it, but I do know there's not enough of me to do this. There's not enough cognitive behavioral
Mhm.
neurologists to do this. So it has to be
Yeah.
dementia specialists. It has to be other clinicians.
Thank you so much. I am going to just respect everybody's time and your time. That was an absolutely fabulous talk. Thank you so much, Ren. That was a tremendously
Oh, my
clear
pleasure.
and excellent talk. So thank you so much. And thank you, everybody, for joining us. And please let us know if you have other questions or topic ideas.